Thank you all so much.
Good morning, everyone. We're going to go ahead and get started. So let me just give you an idea of what's going to happen this morning. Is that we have our panelists. I'm going to introduce them in a few moments. Each one of them will hold the floor for about 10 to 12 minutes. And then after their discussion, we'll open up the floor to you all for any questions that you may have. And then once that's done, we'll be done. So my name is Abdul Henderson. I'm the executive director of the Congressional Black Caucus. This topic this morning is very near and dear to my heart because prior to coming back to Capitol Hill, I had worked on a lot of gun violence issues, a lot of gang intervention prevention when I was chief of staff to Diane Watson from Los Angeles before she retired. So this panel this morning is the effects of gun violence on the mental health of the community. And our three panelists, Dr. Doriane Miller, who's associate professor of medicine and the director of Center for Community Health and Vitality. Then we have Mr. Jalon Arthur, who is the program director for CeaseFire, Illinois. And we have Sonya Clay, who is the government relations representative for the American Academy of Family Physicians. Now, Dr. Miller has been providing care to underserved minority populations for more than 20 years. In addition to her role as a primary care physician, she has a special interest in behavioral health. Under her leadership, physicians, educators, and community members work to improve population health outcomes for residents on the south side of Chicago through community engaged research, demonstration, and service models. And now for each person, I have a lot to say about them, but I'm only going to stay on the very high end levels of what they do. But these are very distinguished and revered folks in this field. Now, Mr. Jalon Arthur serves as the program director of CeaseFire, Cure Violence Illinois' program partner, and oversees management of 24 program sites, 18 of which are in Chicago and 16 that are outside of Chicago. CeaseFire's hospital and interruption program and all three level 1 trauma centers in Chicago, and CeaseFire's or high school initiative on Chicago's west side. With more than 11 years of program experience at CeaseFire, Mr. Arthur has introduced innovative violence intervention strategies and has played a strong role in national and international replication of the Cure Violence health model, including in places like New York City, Baltimore, New Orleans, Puerto Rico, and South Africa. And then finally, Ms. Clay, Sonya Clay, has more than 20 years of combined advocacy on Capitol Hill, including work within the U.S. House of Representatives with Representatives Barbara Lee and Steny Hoyer. She also has years of experience advocating for municipal clients and nonprofits on health, education, social services, and consumer issues. Now, with the American Academy of Family Physicians, she handles their drug policy and public health and engages the House Energy and Commerce Committee and the Senate Health, Labor, and Pensions Committee. So before I turn it over to Dr. Miller, I'll just say, personally, I've witnessed the effects of gun violence and the mental health impacts that it has on communities of color, especially the Black community. And I was born and raised in Los Angeles. I grew up in LA during the time of the early 90s, where our neighborhoods were plagued with guns, drugs, and gangs. And while I went to Crenshaw High School, if folks aren't familiar with Crenshaw, it's boys in the hood, love and basketball. those are two prominent movies out of my era that were produced. But, personally, I lost 7 friends in high school to gun violence. And to see the impacts that it has on families, on the economy in our neighborhoods, it has a devastating effect. And once I became more involved in the policy aspect of how do you counter a lot of these issues, I always wondered, I was just like, what a mental health impact does this have on the community? And then it wasn't until years later when I joined the Marines and deployed to Iraq and, fought in what I call another war, because I call my experience in the early 90s the concrete jungle wars. And then I went to Iraq to fight the war on terror. And then I witnessed, from on a global perspective, the impact of trauma, and never really realized that, when you live in an environment where you're exposed to gangs, drugs, and violence through gun use, those are traumatic events, and our neighborhoods were plagued with that. Just on top of the helicopters flying over our houses at night, all hours of the night, flying, shining that light, in your homes, in your neighborhood. It has a traumatizing effect. And I really did not realize that until I came back from Iraq and had to deal with issues of mental health on my own after I, reintegrated myself back into civilian life. So I'm glad Ms. Kelly has taken up this issue. If you have not seen her report, she has the Kelly report, which focuses on gun violence in America, which is very good. So I would say definitely check out her website where the report has a link to it, and take some time to look at it, because it has some great data. And it has also some good recommendations in terms of potential solutions and possible outcomes if we're able to implement some of these solutions. So I'm going to turn it over to Dr. Doriane Miller to add her perspective on the topic.
Thank you so much, Mr. Henderson, and thank you, Congresswoman Kelly, and also Dr. Puckrine for having us here today. I'm absolutely delighted to be here and to participate in the conference in a subject that's very near and dear to my heart. As Mr. Henderson was mentioning during the introduction, I'm a primary care physician. I'm an internist, and for those of you who are not familiar with that particular profession in medicine, I'm a doctor for adults, and so I take care of high blood pressure and diabetes and prevention issues solely for adults. And you may ask the question, why is someone who is here as a primary care doctor on a panel that involves gun violence and the mental health of the community? And it comes from a few perspectives for me. One of which is certainly a very personal perspective. I was born and raised on the south side of Chicago, although I've not spent my entire life there, but came back to Chicago about 12, 13 years ago after having lived on the West Coast and also on the East Coast to experience a community for our young people that was very different than the very warm and loving and supportive community that I grew up in the 1960s and 70s. Many people think that violence and poverty are inextricably linked, and they are not. There are people who grow up in communities where there is sufficient social capital and protection that oftentimes will help kids to navigate waters that sometimes can be rather tricky. And the community that I grew up in the 60s and 70s, and particularly when I was younger, was the community of Woodlawn. And at that time, it was the rise of what was known at that time as the Blackstone Rangers. Some of you may know them as the Black Peastone Nation or the El Rukans. These were the young men that were in our community along with the disciples. And so our community was split from east to west. Disciples had the west side, the Black Peastone Nation had the east side of the community. And we lived on the west side of the community, but the grandmother of the leader of the Blackstone Rangers lived on the west side of the community, and Jeff Fort, who's her grandson, used to come and visit our block. My parents were there, very hardworking people who were also involved in the community. My mom worked for one of the programs that was sponsored through President Johnson in his Great Society program. And the evening that my dad was had to hide in his car because there was crossfire going on right in front of our apartment building, in which he decided that it was time to move our family out of the community, was a very heart-wrenching decision for my family because they wanted to stay but felt as if they needed to do what they needed to do to protect their family. Flashing forward a bit to my work as a physician on the south side of Chicago and seeing my patients come through a community health center where I worked with what I considered to be traumatic experiences that were not necessarily talked about, but that were shown on their bodies was something else that also stimulated my interest in this topic. Being a doctor, and I'm going back to some of Dr. Murthy's comments a little while ago, and particularly the experience of his parents and having the privilege of people sharing their stories with him, I have that privilege as well. But the stories that my young patients from age 18 through their late 20s would share would be stories of, my head hurts, I can't sleep, I drink too much alcohol, I smoke too much marijuana. When I would ask them a little bit about the background and their social history and how they were doing and managing, they would say, oh, I'm doing just fine. And oh, by the way, I was shot about 1.5 years ago. By the way, I lost my brother or my sister about 1.5 years ago. I would go through their physical complaints and symptoms and ask the question, do you think that there's any relationship between what's happened to you in your personal life and the physical symptoms that you're having right now? And the answer was no. Next question. When I would come to the physical examination portion of our visit and I would take a look at their bodies, there were tattoos, sometimes with a very detailed picture of the person that they lost as a tattoo on their body with the year of birth and the year of death. Usually people who had been born somewhere from the mid-'80s to the early '90s, along with the year in death with a rest in peace. Sometimes they were professionally done. Sometimes the tattoos looked like someone had done them very casually. And I would start asking questions about what is it that's affecting you in your life. Well, the connection between trauma, psychological health, and physical health was something that people did not want to have a conversation about. As I started thinking about this in greater detail, and this was back in 2009, 2010, Doriane Albert was killed at Fenger High School. And so that video went not just across the United States, but it was worldwide, and the young man that was killed outside of Fenger High School, and thought about the impact of trauma and lived trauma on our communities. I had the opportunity to receive some grant funding through the American Reinvestment and Recovery Act through our Institute for Translational Medicine at the University of Chicago Medicine to do work in the area of community engagement. And I was asked by my colleagues, who are mostly basic scientists and bench scientists, well, so what are you going to do in this area of community engagement? And I said, I'm going to go talk to the community. And they said, but what's your intervention? What are your outcomes? What's your hypothesis? And I said, to go talk to the community to figure out what their concerns are around health and well-being, and then to figure out a way in which we can take the strengths that we have as the University of Chicago, not just the medical center, but across the university, in order to help impact some of these situations and ills that people are experiencing. And from that, a program called Community Grand Rounds was born. The first 3 topics that our community residents decided that they wanted to talk about, and these were people who were direct service providers in the community, as well as community redevelopment agencies. They said, let's talk about violence, 1, 2, and 3. But it wasn't about the issue of you need to do more surgery or there need to be more trauma centers on the south side of Chicago. They were concerned about the mental health and well-being of young people in the community that had been exposed to violence. Graduation rates for African American young men on the south side of Chicago for public schools are less than 50%. They've actually gone up over the years, but they're still less than 50%. And you have to start asking the question, why are these graduation rates so low? What's going on within the context of community that would affect graduation rates? Now, some of you may be thinking, well, we're here to talk about health. What about the issue of graduation from high school? Well, and the education level of a young man or a woman is a very strong predictor of their future health. And when you think about their social circumstances being impediments to have healthy lives, to have healthy families, again, all of these things come into play. And so they asked us to address issues around violence mediation and violence interruption, post-traumatic stress disorder and depression in the face of community violence, and also domestic and intimate partner violence. We also addressed issues around asthma, diabetes, obesity, and other topics that are much more traditional health topics. But the first three things that came out as things that we needed to address in partnership with community-based organizations were the issues around violence. And so we developed our Community Grand Round series. For those of you who are familiar with the more medical Grand Round series, it's usually a bunch of esteemed professors who come and sit in a room for an hour once a week. They listen to a lecture that is about an inch wide and a mile deep on a given topic. There's an opportunity for 3 questions at the end, and then after that, people scatter off to go back to their either clinics or their laboratories. But our Community Grand Rounds are community events that last between 2 or 3 hours, either on a Saturday afternoon or in the evening, in which we bring together people from the university who are doing work in the same area that people are in the community to sit on the same platform to talk about these issues and to think about ways in which they can provide not just education, but connections to resources either at the university or in the community around these topics. The first Community Grand Rounds that we held was on the topic of post-traumatic stress disorder and community violence, and our community partners asked me to present the information and materials in a way that reflected the lives and experiences of our community members. And one of our community partners said, why don't we do a play? Because we don't want a bunch of talking heads up on a screen talking at us. We want to be able to interact. I looked for information that was applicable to the lived experiences of people in our community and couldn't find anything. And so from that, decided to sit down to attempt writing a one-act play around a 15-year-old protagonist whose best friend was killed in a drive-by shooting during the summer between freshman and sophomore year of high school. The play was called It Should Have Been Me, presented at our first Community Grand Rounds with attendance of about 150 people at a high school where they had experienced the death of a young man just 3 weeks earlier who was visiting his grandmother and sitting outside on her porch in the Auburn-Gresham neighborhood on the south side of Chicago. The play was subsequently picked up by a local theater company on the south side and played for 2 years in rotation with more than 60 schools from across the city, 10 to 18-year-olds having the opportunity either to come to see the play at the theater, but we also took the play to the schools. We had the opportunity to do post-play talkbacks in which the actors, psychologists, members of CeaseFire Cure Violence came and were post-play discussants to talk to young people in the audience. And when we would ask the young people in the audience, how many of you have been directly affected by violence in your community? 70 to 80% of every single audience from the age of 10 on up put their hands up to say that they had been directly impacted by violence in their communities. We also had the opportunity to bring the play here to Washington, D.C., and I'm so glad to see Judge Burnett here in the audience because it was his organization that was able to have us to come and to present to the National African American Drug Policy Coalition meeting in September of 2012 at Howard University in order to have a staged performance of the play, It Should Have Been Me, along with a talk back in the audience. The partnership with our community partners around this process and around Community Grand Rounds in general has been terrific because it's been a community-informed and community-directed process. I consider myself in many ways to be a junior partner in this, in that I serve as convener, but the people who are leading and directing this in partnership with the university and with my colleagues are people from the community. Partnerships from our local initiative support corporations, New Communities programs, direct service providers such as South Central Community Services, Gary Comer Youth Center, Demoiselles to Femme, and Chicago Youth Program, and others. We've had the opportunity on multiple occasions to partner with representatives from CeaseFire Cure Violence Illinois, both as post-play discussants, also to address this issue of what happens afterwards. I am very tired as a physician of picking up people right before they're about to go over the waterfall rather than having them to drop into the water in the first place. And so I think that the role of thinking about the engagement of community and prevention, and particularly around this issue of gun violence and mental health in the community, is so critical. Because one of the things that I've learned from Dr. Gary Slutkin, who is the founder of CeaseFire and Cure Violence, is that violence in our communities is like an epidemic. Once we see it in one person, it can spread to another and another and another. And the question of thinking about preventing violence upstream, whether it be through secondary interventions, such as the ones that take place through the interrupters, or primary prevention, starting at a very young age, I think are critical in helping us to have a healthy and resilient society. Thank you.
Well, thank you, Dr. Miller, for your presentation. I'm going to turn it over now to Jalon to do his presentation.
I'm going to stand right here just so I can see the people at the back of the room. Can everybody hear me? It doesn't feel like this is on. Yeah, can I borrow yours?
Yeah, good.
Talking.
I'm talking. I'm not hearing nothing. Yeah, this will work right here. How's everybody doing this morning? All right, for sure. And first, on behalf of Cure Violence, I definitely would like to extend a humble appreciation to Congresswoman Kelly and everybody who participated in making this event, happen. I mean, it's a very critical topic that we're talking about, gun violence and the mental health of the community. And I'll just start off by a disclosure, similar to Abdul's experiences. I've been on both sides of the gun, victim and offender, and I've experienced the impact of gun violence both through a personal and a professional lens. Engaged in a lot of gun violence as a young teen on the south side of Chicago, like my sister right here. Participated in a lot of gang violence. Since this is being recorded, I won't disclose my former affiliations. But it truly is an honor to speak about this important topic in front of everybody here. So Cure Violence is an evidence-based health approach, scientifically proven to reduce violence. We're talking about 4 independent evaluations, 30 to 50% reductions in shootings and homicides. So we're talking about gun violence. And our founder, Dr. Gary Slutkin, is an epidemiologist who actually applied the science of reversing epidemics such as AIDS, cholera, tuberculosis, applied that to the violence as an epidemic. And actually, why does it make sense to really view violence through that health lens? It makes sense for a number of reasons. First, violence actually behaves like an infectious disease, like a cholera, like a tuberculosis, like an AIDS. The first thing, if you think about, the concentrations, the clustering of violence. If you think about violence in your own communities or your own respective cities, violence has a tendency to be clustered. It's not evenly distributed. So if you're in the south side of Chicago, communities like Inglewood, like Woodlawn, like Auburn Gresham, like Roseland, are experiencing higher levels of violence. And then you have communities, maybe like a Beverly or a Hyde Park that's not experiencing violence, at the same level. And it's the same whether we're talking about California. I mean, Abdul's experiences, violence is definitely highly concentrated in certain areas. The other thing, if you think about transmission, the transmission of violence, it spreads like an infectious disease as well. So we're talking about the more one is exposed to violence or other infectious diseases, the more likelihood of that individual actually becoming symptomatic and actually displaying those symptoms. There's an abundance, a wealth of research around, the exposure of violence, and whether it's domestic violence, whether it's street violence, whether it's sex violence, the more one is actually exposed to it, the more likelihood, again, for one to actually, start behaving in a violent manner. So, even outside of the science, at the community level, at the ground level, What do you get from more shootings and killings? More shootings and killings. You see it spread in that way. The other thing is, if you think about, spikes in violence and even relapses, and if you look at whether it's infectious diseases or violence, you see these spikes. And sometimes it could be seasonal, just like, we talk about flu season. If you're in Chicago, probably around spring, summertime, a lot of people commonly refer to that as the shooting season. So you see these periodic spikes and even relapses, after it's been treated. But most importantly, when we're talking about violence, viewing it as a health issue, if you view it as a health issue, then it impacts the way that we actually view it and treat violence, as a health issue. And so when we're talking about treating it as a health issue, we're no longer talking about good versus bad people. We're talking about behaviors. We're talking about learned behaviors that can successfully be changed. They can be modified. And so, this approach is actually, it's been applied, and it was first actually applied in 2000 in the West Garfield Park community, which at the time was one of the worst communities in this nation. And after applying this health model, largely, interruption, changing behaviors, changing norms, we saw a 60% drop in shootings and killings in that community, in that particular area. And so, what we're talking about at the ground level is really this. If you're serious about stopping shootings in any community, and I mean really serious about stopping those shootings, you have to be able to work with shooters and potential shooters within those communities. So CeaseFire at the ground level, what it looks like is we're working with shooters, potential shooters within those communities. We're not working around the issue. We're going right directly to those shooters, to those potential shooters. And oftentimes these are individuals who have been alienated in the community. They're feared, they're resented, and they're viewed as, they're beyond help. Incarceration is the only answer for these youth. And so we're actually working directly with that population. And who's actually working with these shooters, with the potential shooters? We're talking about employing credible messengers, violence interrupters, outreach workers, and it's similar to other fields in health where you're talking about former substance abusers working with current substance abusers. You have the epidemics such as, Ebola, where even, people who were previously infected are now coming back to their communities and actually being a part of the solution. They're actually, providing services for this population. And so the thing is with this program, and I've been here 12 years, I've worked in every single program role, I can tell you from experience, you cannot train the wrong workers to be the right workers for this type of work. We're talking about individuals born and bred in these communities, know the history and the current reality as far as the violence. They have a certain measure of street credibility, which is critical to actually be able to gain trust and to be able to stop shootings on the front end. And also to be able to prevent retaliations. So we're talking about these credible messengers. There's a careful selection process, but then we impart them with training, and strategy. And so the other thing is, we're talking about local service providers. We have local offices, but also what's important is the strategies. The analogy I always use is keeping up with the streets is like keeping up with technology. You can become outdated in this field overnight. And so if you're using a 2012 strategy in 2015, you're not maximizing your impact. And so whether we're in Chicago, whether we're in Woodlawn, whether we're in Roseland, whether we're in South Africa, we're looking at the current dynamics, what's going on as far as the violence in that community. And actually we're using the credible messengers, we're using this public health approach, but we're developing these strategies that make sense for what's going on today in the community. And so, like, what's going on as far as the violence in Chicago right now? What are we seeing as far as the violence? Where some of the common violence triggers that we're seeing is actually, for one, a lot of group tensions. So Chicago, Chicago is viewed as a gang city. But the evolution in Chicago as far as the gangs have changed a lot over the years. And now, it's not just about these larger umbrella groups. Right now, you have a lot of these smaller cliques, smaller teams, smaller crews. every single block, every other block could be something different. And so, we're developing a lot of strategies to deal with the group tensions, within these communities. Another thing that's driving violence, interpersonal conflict is major. A lot of interpersonal conflict going on, and a lot of times some of the misinformation that goes out is, you have two individuals who have a conflict, but maybe they had an affiliation, so it's just automatically titled as gang related. When in actuality, the gang is secondary. It may not even have that much to do with this interpersonal conflict. But right now, today, and again, talking about, current strategies, current trends, social media is driving a lot of the violence that we're seeing, whether it's in Chicago and in a number of our different cities, replication sites, and even on a global scale. You have individuals who are inciting violence on Twitter, Instagram, YouTube, Facebook. All of the different cliques, crews, you can go, if you're in Chicago, you can punch in their little clique name, crew name, and you see this collage of videos where people are actually antagonizing and cyberbullying, I guess they use that term as well, but really, taunting the other side. Rival groups, they're taking credit for violence that's occurring, and you see the social media. I mean, it's not just about people just flaunting and doing, like, people are really getting shot and killed behind some of this. I mean, some of the more stuff that's really made headlines and stuff. Even when we had the little JoJo situation. When you had somebody who actually posted where he was at, was engaging in a war, group on group type of situation, posted where he was at, and they came and they shot and killed him. And this is happening time and time again in Chicago and other neighborhoods across the city. And so as far as strategies, we have to have strategies that actually address each of these different violent triggers. And so, some of the things that we do, especially as far as the group tensions and some of these other violent triggers, we do a series of summits. Every single month, we're doing different summits in different communities, bringing high-risk individuals, different cliques, different crews to the table. And so why is that important? Anytime that there's epidemic levels of violence, there's always these, community forums and community town hall meetings where you bring in key stakeholders where they're talking about, they're trying to develop these strategies to get the violence down in the community. And those are good. But at the end of the day, a lot of times the missing element in some of those forums, some of those town hall meetings is the individuals, the groups who are actually engaging in the violence are not there. They're not represented in that room. And so at the end of the day, if you don't have buy-in from those individuals, those groups who are engaging in the violence, then you're only going to go so far as really getting the violence down. So these summits that we actually put together, we're actually bringing these groups to the table. And it's not for the purpose of preaching to them. We're actually engaging in two-way dialogue. We're talking about the real issues that's going on in the community. And we're collectively talking about potential solutions. We're negotiating peace. We're talking about different strategies to navigate around violence and to be able to mediate conflicts that are existing right here, in a community. We're doing role plays around common situations that lead to violence, and this is all in a safe space. So it gives us an opportunity to really, we've been able to negotiate some peace agreements that have lasted and have resulted in some significant reductions in shootings and homicides in some of our areas. But also, back to the social media thing. We're using social media, the detection is a critical piece of our work. We're working in non-traditional hours. This is not a 9-to-5 operation. Our hours are pretty much dictated by the evidence. If the shootings are more likely to happen between 4 to midnight or 6 to 2 o'clock in the morning in this particular community, then those are the hours that we're out there. And we're keeping our ear to the streets and we're anticipating, different conflicts that are happening, and we're intervening right on location. And so the social media also is another tool another detection tool that allows us to be able to see what's going on in different neighborhoods, the different groups, the different cliques, and we're able to actually respond, immediately to some of these situations. But we also have a social media campaign now. It's a public education campaign called Past 36 that we're utilizing social media, the same way they're using social media to put out negative stuff. We're utilizing now social media to put out some positive messaging around the different issues. And so one other quick and important thing about this program, it's very focused, it's very concentrated. We're not trying to do everything. Very concentrated. And so, part of what's critical as far as this program, being able to thrive in other communities is also mapping and collaborating with different service providers and different resources within the community. Because, Cure Violence plays one particular piece of the solution, but there's other resources that are critical in the community. And so we have to be able to collaborate with those, and those relationships become critically important because a lot of times, we serve as a bridge to link resources with our population, highest risk individuals, and other service providers within the community. Sometimes there are services within the community, but the population, because of this gap, they're not actually accessing, those services. So a lot of times the differences between our population getting those services and somebody else could be life or death. So us having those relationships allow us to be able to get our high risk clients, to be able to benefit from those services. And so some critical services, employment, and I'm gonna wrap this up, employment, education, but trauma is a huge one. Right now we're looking at trauma on 3 different levels. Trauma as far as our staff themselves, they're being exposed to a lot of trauma, this kind of first responder type thing, but our population that we serve being exposed to trauma, and then the community at large. So in closing, this program, it really works. I'm very passionate about it. I've seen it, and it definitely, and I look forward to having more conversation in the Q&A. Thanks.
Thank you very much, Jalon, for your presentation. I'd just like to add in terms of as violence as an infection. As I think about growing up and looking back, I always used to remember how the school year would operate. It was, especially living in an area that was plagued by gangs. Is like in the fall, you would have these interpersonal conflicts. The winter, even though California winters are pretty mild, there's no snow on the ground, but 60 degrees, people would stay indoors. But and so during these interpersonal conflicts over the fall would not necessarily spill over in the winter, but as spring and the summer came, that anger, that tension, that frustration all emerged when it got hot. And on top of it being hot and people being frustrated and angry, you have these issues that you're dealing with in the streets, and it also could be boiling what's going on at home. You're in a domestic situation where there's abuse, there's drug abuse, etc. And then the summertime came and it was just like this explosion, and you're like, oh my God, what is happening? Because it's you would just see all these people fighting, these stabbings, these shootings, etc. And then it always reflected. I was just like, man, I went to war for the United States of America, and we didn't lose any lives in my, stint in 6 months in Iraq. And so I lost more friends on the streets of LA than I did actually serving in actual combat. And so that strikes me as we can do better in terms of providing services for our communities, because there's no reason why violence, trauma should be prevalent. But those are among other institutional issues and access to contraband, illicit materials that have been flooded into our communities since the late 60s, 70s, 80s. So with that, I'll turn over to Ms. Sonya Clay.
Okay. Let me know if you can hear me. It's definitely a pleasure to be here and to speak on behalf of the American Academy of Family Physicians. And I am actually originally from Alabama. So from the rural community, but my experience working on issues pertaining to violence really was working with my previous work with the American Academy of Pediatrics and working on child abuse prevention policy in response to Penn State and the child abuse issues that were going on then. And then also in response to Sandy Hook, led a public health and gun violence coalition with a number of public health and medical associations. Though we weren't successful in terms of getting some positive gun violence policy enacted, it really was a great organizing effort to pull organizations together and to really talk about this issue and the continuum of violence. Because what I find is, at least from the national perspective, and I'm going to talk mostly about policy, but from the national perspective, there are a variety of different silos: the child community, the adolescent community, and in some cases the women's community, and then some communities that deal with different types of violence. But again, I'm very passionate about this issue, and as the other speakers said earlier, the good news is that there's something that we can do, and there are interventions that are working. In addition to the interventions that they're talking about, there are a number of other interventions that have been enacted into law and that are moving forward. And then there are some upcoming opportunities that are happening right now in Congress that people should know about. So really briefly, of course, AAFP is a membership organization of 115,900 family physicians from across the country. We see protecting, and I'll talk about this also from a children's health perspective, because again, I think this issue of prevention is really key. But we're committed to protecting children and adolescents from violence. We definitely work to enact gun violence strong gun violence policy. And of course, gun violence has really strong societal costs. I mean, what's interesting to know is that the cost of gun violence is more than what we spend on obesity. It's more than what we spend on foreign aid, and that the costs are in the billions. It costs $8.9 billion in terms of ER visits and hospitalizations and injuries, and an indirect cost to society, it's $229 billion. So what we spend in foreign aid is $30 billion. What we spend on obesity is $224. So obviously, the impact of gun violence is quite substantial. For family physicians, again, obviously we care about this issue. 1 out of 3, I mean, 1/3 of our family, 1/3 of our patients are those who have been exposed to violence. And obviously, people who are exposed to violence are interacting with the healthcare system more than other people. What's also important to know is that, young people, children and young people are particularly at risk for all forms of violence. So when it comes to issues like child abuse and neglect, most children who enter the foster care system as victims of abuse and neglect are on average age of 4. That again, for those who are exposed to community violence and gun violence, 18 to 24 or 15 to 24, that young people are the most vulnerable to being exposed to violence. And then also for issues pertaining to intimate partner violence that impacts women, the ages of 18 to 24, young women are most vulnerable. So the important thing to know is, again, we're talking about young people exposed to violence, at a very early part of their life, key stages of their development, and also the impacts are lifelong. I think what got me really passionate about this issue is hearing about research that basically, it's the Adverse Childhood Experiences Study, and I don't know how many people have heard about that, but it's the study that basically was started. It was a Kaiser Permanente research study that was evaluating obesity patients and basically made this correlation between adverse events that happen early in life, child abuse, exposure to violence, death of the family, or being a child of a substance abuser, and it made a direct correlation between that and chronic health diseases. Heart disease, cancer, STIs, unplanned pregnancies, et cetera. That people literally spend their entire life trying to really address and respond to the impact of those experiences that happen earlier in life. And that for those people who have multiple traumatic experiences, that they have shorter lifespans and that they are sicker. So just knowing that there's a direct correlation between what our physicians see and what, and what occurs. It's very compelling, but it's also really a call to action that there's something, we need to do something about this. I think what's also really compelling is the fact that for all of the young people and others who are exposed to violence, very few people actually get access to mental health care. Particularly children, they often don't have access to trauma-informed care or mental health care that they need. And this also has an impact in terms of education and economic outcomes. There's an NEKC report that came out last year that said that for young people, and particularly young people of color, and there are definitely multiple factors that impact it, but if young people, that in many cases behavioral health issues impact their ability to perform in school, and that by the age of 8, young people who are behind often don't catch up. So obviously that's going to have an impact in terms of their lifelong well-being. And then of course, for young people who are exposed to violence and other traumatic events, the impacts are obvious. Anxiety, depression, PTSD, the somatic symptoms in terms of sleeping and other health issues. And as I mentioned before, violence is interpersonal often. So, the good thing is that even though the medical community and the public health community, I don't feel like we're doing as the type of work that you all are doing, and it's very exciting, but there is this coalescing among public health advocates and the medical community about this issue of dealing with violence as a public health issue. I know that there are a number of organizations that have had policy on violence for quite some time. I know that there are a number of different groups that are talking about this issue of trauma and the repeated exposure to trauma in the context of toxic stress, and that for particularly young people, well, one from for infants who are exposed to toxic stress, having a parent who's exposed to domestic violence or being exposed to violence, it can have an impact on their neural development. So it can have an impact on brain size, development, language, and motor skills. And this is even before they're at an age where they're going to school, they've already been impacted. And it's this toxic stress that is in the absence of a safe and supportive family environment. But there are 2 key foundations that are really looking at this issue and other issues, but looking at this issue of violence and safety as a community health issue. That Robert Wood Johnson just had, Robert Wood Johnson just had a report that came out that talked about the importance of looking at community, health in all communities, and that the markers of a healthy community is that it's a safe community, but it's also a community where all stakeholders are working together for a more equitable community as well. And that's something that's very exciting. And Robert Wood Johnson is a pretty effective foundation in terms of supporting programs, policies on a variety of different levels. So I think it's going to be exciting to see what Robert Wood Johnson comes up with and the different stakeholders that they bring together on this issue. Another key stakeholder that I think is also important is the Kellogg Foundation. Just this past week during National Public Health Week, I think it's the president of Kellogg talked about the importance of addressing health, addressing equity, equality, race in the context of public health, and really put out a call to action to the public health community to deal with really the sort of, what's underneath the surface for why some people are more vulnerable to violence and some people are more vulnerable to being at risk and versus others. And there is a question of equality. During the economic downturn, when families were more stressed economically, you saw an increase in child abuse and neglect. So there are these multiple factors that put a variety of people at risk for violence. And of course, for community violence, it is in some cases it's multiple factors. So it's not just one, but it's being young, being male, being low income, and being in a community that is disadvantaged, and also being a substance user and abuser. It also puts you at increased risk. And then of course, it has an impact on communities as well. There's a really interesting article that was posted in the New York Times, I think today or the last couple of days, that talks about the 1.5 million missing Black men. And it just talked about the fact that, it just talked about the fact that that with violence and the impact of violence, Take your time. I'm sorry. that the impact of our policies are having an impact on our communities, and that obviously when children have families who are incarcerated, that is going to have a traumatic impact on their mental health. But the beauty is that there are programs that are helping to build community strengths, build family strengths, to build community and family strengths. And so I think that really captures, some of the activities that are happening in the public health space. So I'm gonna just go through a couple of key policies that some of the organizations nationally are working on. I'm really sorry. From a child and family perspective, the home visiting program has been an effective model for what has worked really well in terms of helping to prevent child abuse and neglect. There have been a number of studies that for some programs, particularly those that respond to the needs of the most at-risk families, that there have been reductions in 38.9% reduction in child abuse. Also in 2013, the Violence Against Women Act was reauthorized, so that law was first in place in the 1990s, and it's actually one of the policies too that is a step forward in terms of addressing violence, not just from a justice perspective, but also from a health perspective, and it does have a number of different policies, one of which is to train health practitioners to screen for violence and also to counsel patients about violence. But the good thing is that since the law has been put into place, there's been a 37% reduction in homicides among women and over 50% reduction in homicides among men in intimate partner violence. So it is preventable, and there are things that we can do because, as I mentioned before, it's all interpersonal, and from a gun violence policy perspective, for those communities that have lax gun policies, there is an increase in the number of homicides, suicides, and injuries, and that even for issues like domestic violence, if there is a home where they have a gun, a person is much more at risk for being killed. So the efficiency and the lethality of guns are important to address, but also the issue of violence is also really key. So from a child and family perspective, home visitation and violence against women programs are really effective. And it's great that those programs have moved forward and implement and have been reauthorized most recently. Within the healthcare sphere, the Patient Protection and Affordable Care Act has provisions that allow for screening for domestic violence and also child abuse within the preventive services. I'm not sure that there's a perfect policy. But I think that it's there, and I think that there are health organizations working to ensure that there are interventions on the other side. So if someone says I've been abused or that I've been a victim of violence, like really making sure that there are programs within the community that they can refer them to. That's important. Another really interesting development that was a program that was authorized as part of the Healthcare Reform Act is teaching health centers. So most physicians are trained in a hospital setting. This is really to bring physicians to communities so that they get their medical training in community settings and in community health centers so that they're getting culturally competent care. They're getting training where they can really kind of train in a sort of in an environment that's very typical for what most physicians are trained. But also it really does promote the model of having a medical home, building that relationship with your physician. And again, there is this move to really increase the medical community's awareness of violence, but also to really take advantage that for those who have a really good relationship with their physician, that access to mental health or screening for mental health or screening for violence can be really valuable. But again, the key is really making sure that the services are available once the person leaves the office. I'm not going to really talk much about violence. Yeah. So I'll just say really quickly a couple of key policies that are moving forward. Education reauthorization is moving forward, and there are a number of different anti-violence policies. Again, this issue of the school climate is very important, both as an environment that could be a safe environment for kids, but also the issue of bullying and exposure to violence can make young people more at risk for gun violence. And then of course there's a mental health, comprehensive mental health bill that's moving forward. Not a bill that's moving forward, but Tim Murphy, who's been the author of mental health legislation in the past, will be moving forward on a comprehensive mental health bill that addresses the need to increase access, to increase training, to improve how current federal funds are being used. We also have mental health parity where, for those who have insurance, that you should be able to get access to mental health services at the same rate as other health services. Again, it's still something that's moving forward and still has its challenges. Obviously, justice reform is also something that has been discussed in Congress as well. There's some bipartisan support. I think it remains to be seen whether or not something will be done. I will say that the CBC has been a really strong leading voice on all of these issues. Members like Congresswoman Kelly, Bobby Scott, Bobby Rush, and so many others. And I think that we should, if we have the opportunity to thank them for what they do, we should definitely take those opportunities, because there are a lot of really important policies that have been enacted because of policymakers like them, but also the work really has to continue. And if I had more time, I'd talk a little bit about budget and appropriations, because I think, again, to have the community-based programs, they have to be funded. So that's all that I have to say. Right.
Well, I thank our distinguished panelists for the information that you shared. And before I open it to the floor, the good thing about being a moderator is that you get to ask the first question. First I'd like to say this issue for the CBC is a priority. We've laid out to where this falls kind of under our jobs and employment section, which, the overall health of an individual, the mental health of a person, that also affects, education. It affects your chances of getting employed and maintaining employment. And so this is a huge priority for us, and the challenge is being in the minority. What can we actually accomplish in terms of getting increased funding or even getting pieces of legislation passed that focus in on this issue. And so we are continuing to fight that fight to ensure that the communities of color, specifically the Black community, have the resources to deal with a lot of these challenging issues. So going into my question, I always had this thing about self-medication and trauma, because generally when you find people who have been exposed to trauma, when they do not have access to health care or they do not have access to someone to talk to, they tend to begin to self-medicate, generally through either through drugs, illegal drugs, or prescription drugs in a lot of cases nowadays, alcohol, et cetera. And so how do some of the programs, and this may be specific to Jalon, how do some of the programs that are out there, how do they deal with the issues of access to, to these type of materials to where folks self-medicate? And the biggest pharmacy in our communities are liquor stores, that perpetuate a lot of the alcoholism that is prevalent in our community. So how do we combat that?
Well, I'll say first and foremost, I think from what we've seen, trauma is normalized in our communities in the same way that violence is normalized. It's so prevalent in the community, and so the way it's viewed, treated, there's it misdiagnosed. So I think, what we've been doing probably within the last year, we've been putting more of a focus on trauma, and it's really been an educational process. So first educating our workers on what trauma looks like in the community, how it gets a lot of times self-medicated and how it shows up in certain behaviors and things of that nature. It first helped us to actually deal with the trauma that a lot of our staff were actually dealing with on the job, and even pre and post. A a lot of people are traumatized. But then more importantly, being able to share that education and link them to the appropriate resources within a community has been critical. We've partnered with C4 has provided, we've gone through some training, mental health first aid. We've partnered with an organization called Shambhala Mindfulness Center. They're providing some trauma-informed mindfulness training for our staff, and we're also introducing that in our high school component, and as well as with our high-risk population that we work with. And we're also working with some other UCAN and some other trauma specialists. So, I mean, I think the thing is, first, a lot of times it's just not properly, it's misdiagnosed and it's not properly viewed and treated. So, I think when you use credible messengers to actually, stand up and educate as far as the issue, and also, start benefiting from some of the treatments, I think it's been better received with our population, in the same manner that, you have people that were once violent that are now, they're living a different way and they're behaving in a different manner.
Anybody else want to add to that?
So for those of you who are familiar with Dr. James Jackson's work as a social psychologist at the University of Michigan, he actually reports that amongst the African American community that we have lower than expected rates of depression, but higher than expected rates of substance abuse. And so I think to Mr. Henderson's point, the question of self-medication, if something hurts, you need to figure out a way to fix it. And oftentimes it's the underlying psychosocial trauma and stress that people are experiencing that historically they say, well, if I go get a 40 ounce or if I get something else in order to help to soothe my pain, because I don't have resources or access within my community to get those mental health services, to get counseling, whether it be through medical services, whether it be through pastoral counseling, through the faith community, that they may not necessarily exist in that way. One of the things that I was very encouraged by with Ms. Clay's comments is the issue of having trauma-informed primary care. As a primary care doctor coming in and stating the question that although I may have other health illnesses, I also have this particular part of my life that's affecting my ability to take care of myself. And what kinds of resources can I access through you, through the system, in order to be a healthier person? Just as a reminder, the World Health Organization's definition of health is the complete presence of physical, mental, and social well-being, not merely the absence of disease or infirmity.
Thank you. Now I'll open it up to the floor if anyone has a question. I'll start with the lady right here. I will most likely end up repeating your question, so bear with me.
I'm just going to be loud then, hopefully. Thank you so much. That was really incredible panel. I work with the National Association of Social Workers in Dublin. And I wanted to share a resource with the community here that's interested. The Institute of Medicine has a group called the Forum on Global Violence Prevention. And actually, CeaseFire was one of our main presenters in our Contagion of Violence workshop. And I think it might be a resource of interest. If you go to the IOM Forum on Global Violence Prevention, there are workshops on mental health and violence, social media violence, contagion violence, and they're engaged in the community. There are webinars, they want people to participate. But the one I really want to talk about is the most recent one on the means of violence. And in it, the CDC Foundation commissioned 3 papers on gun violence. One on alcohol, one on youth at risk, and one on at-risk populations. What I found astounding is learning that the research dollars, the research message has been squashed, killed for decades by lack of funding and support. Only recently has the CBC been able to, again, do research. So, they talk about collective violence, social and cultural aspects. So my informational commercial right now is also a question to the panel about what would be a message we all could take back about what are the research needs? What do we need to know about gun violence, about mental health that can be used to fund research, to fund policy, to inform policymakers so that we can really make a difference in our communities.
Dr. Miller.
I think it's pretty loud, right?
So the question of what are the research needs to affect violence and mental health in our communities is the gist of the question, I think. Okay. I think that one of the research areas that I would like to see covered as a primary care provider is where should mental health and supportive services take place and where are they most effective? So the question of testing in a rigorous fashion place-based strategies, because for many reasons, people don't necessarily come to a psychiatrist, a psychologist, in contact with a licensed clinical social worker in order to receive services. But kids go to school. Most kids go to school every day. And they may have contact in terms of a family unit with the faith community. How can we figure out better ways to leverage other organizations within our community in order to deliver these services, in order to impact mental health for people who have been exposed to violence in the community?
I think one thing that we talked a lot about is community strengths. So I think an important intervention should include community strengths, but some research on some valuable community strengths that might be helpful in terms of preventing violence and how to disseminate those community strengths and how they both address mental health and trauma as well as violence prevention. But I know on this issue of CDC research, I'd love to hear more because all that I know that they're doing is National Violent Death Review.
The gentleman.
NVRs.
Oh, sorry. The gentleman in the corner over here.
Yes, I'm Dr. Roberts of the National Medical Association and public health physician by background, currently working in environmental health. But in the 1980s, I was a researcher on violence intervention in Kansas City, and it was funded by the Centers for Disease Control, prevention. And my understanding is that I wondered if you could talk a little bit about the role of the National Rifle Association in preventing research and where things are, and maybe what kinds of things that CBC can do.
Whichever. I mean, I can speak really briefly. I mean, I think their imprint has been very obvious. The Sandy Hook, the response to Sandy Hook, both from the administration and from policymakers, was really strong. But they have been effective since the 90s in really making it clear that if you support gun safety legislation, if you remember after the 1990 crime bill, there was a sweep of members who voted for that policy that included gun restrictions. Many of them lost, and that's been a threat for the last 20 years. I think that threat was still prevalent during the last couple of years, so as a result, nothing moved forward. But in terms of what they've done, they've been effective in terms of stopping effective and very simple gun safety policies, such as to strengthen the background checks. But they also, I know for our community, that what's been impacted is they've been effective in terms of moving forward gag legislation, gag policy, gag law, to prevent physicians from being able to even ask if families have a gun in their home, which is part of the anticipatory, guidance. Like if you have a gun, this is what you do. If you have a kid who has a potential mental health issue or something else, you shouldn't have a gun, or that you need to keep it locked. So they are relentless. It is resulting in an increase in a gun culture. And I think there are so many different policies that they've been able to be restrictive, both within DOD, DOJ, and other areas where you're really not allowed to do anything that's common sense. So there really needs to be that political climate that they talked about to get something even basic done.
In addition to that, the NRA, has a great deal of resources that they'd flood the market with their information in terms of pro-gun agenda. Now the CBC has done a great deal in working into establishing, universal background checks, which a great deal of them support. But the challenge is being able to effectively, and I think the challenge is externally, not internally from the congressional point of view, but externally, groups need to match the NRA's outreach in terms of, the need for stricter gun restrictions on who can get one, what's the mental health capacity of a person trying to purchase a weapon, et cetera. So I saw a bunch of hands. Any questions on this side of the room? Judge?
I'm Judge Burnett, CEO of the National African American Drug Policy Coalition, based at Howard University. Howard University has a sub-grant of $13.5 million from NIH. And I look at this very issue. I'm the chair of the advisory committee looking at prevention of violence in Black American communities. We have initiated here in DC 2 pilot programs. One dealing with 12 to 17-year-old youngsters, where we go into Richard Wright Charter School and talk about this issue and try to encourage teenagers that Black lives matter, not only with reference to gun violence, but police officers, but in the community. We send speakers into the schools, speaking to kids 3rd grade and up about the value of life and the potential of life. And I had the advisory committee, the Capstone Project, looking at that program with that school and with my Angela school to come up with answers on how we change attitudes of youngsters 3, 4, and 5 years of age on the value of human life. So we're on the ground trying to come up with solutions to these problems right now. And I would like for the whole panel here to get my business card, because I'm overseeing the Howard Initiative in this very area. I just thought I'd pass that on.
Okay.
Thanks.
So you know that, matter of fact, the total grant is $13.5 million grant. New Hampshire, Howard has a sub-grant dealing with this precise issue.
Okay. We'll do a few more questions. I'll go to the young lady with the orange in the back, and then I'll go to the lady on her right in the gray jacket.
Thank you. I'm Renee Stanley. I'm a physician. I'm also the deputy director of the Center for Reducing Health Disparities in Nebraska. You guys there are from Nebraska. I'm not the only one over the population reduced by 50% now that I'm not in the state right now. I admit that I'm ignorant to this topic. I'm a vaginologist, so it's kind of outside of what I do, but I'm sure it impacts my patients. And while I asked about intimate partner violence, I realized I never asked about, have you ever lost a kid? Is anyone in your family been impacted by violence and how that impacts you? But I'm going to ask you a harder question, because while African Americans represent 4% of the Nebraska population, I moved from Washington, D.C., and so on TV constantly there was violence and other things that would happen in the city. And when I moved to Nebraska, whenever there's a violent crime, over the 5 years I've been there, happens in North Omaha, where it's highly concentrated by African Americans. So questions that I get from white people have been things like, and it taps into what you're saying about poverty is not necessarily correlated to violence, because I think that's what a lot of people think, and I was like, I think that too, so I'd be interested in an elaboration on that. But questions that I get is why, if you compare white poor communities to Black poor communities, you'll see high levels of substance abuse, you'll see levels of intimate partner violence, you may see levels of bar fights, but you don't see the murders in the same way that you see in Black communities. And then there's also a gender disparity as well. So women reside in the same communities. Can you talk a little bit about the gender differences and why it's still a larger male issue than female issue, and how that ties into conflict resolution? And then are there specific roles that you see, especially with CeaseFire, for women to play who are in the community, and what that would be? So that's a couple of questions in my mind, and just having really thank you for an enlightening panel.
You want to start on that?
So I'm going to go back to something that Ms. Clay was saying a moment ago and links into the issue of the linkage between poverty and violence and crime. African American communities have been poor for many years, but the loss of jobs and job opportunities, particularly for African American men, I think has been one of those preceding factors that have been left to figuring out ways in which one can make a living, people becoming involved in either crime, drug culture, and then the subsequent control of territories around many of these things, I think is certainly a piece of it. But also in other communities where poverty has existed, there's been also much more of a social capital and framework. And also prior to desegregation, and this may sound somewhat controversial, but for some of our members in the audience who are a little bit older, the issue of mixing of socioeconomic groups within the same community. My parents were born on the south side of Chicago in a community that's now called Bronzeville. Within their community, and any given Sunday at church, there were African American doctors, lawyers, business people, insurance people sitting next to the barbers, the chauffeurs, the maids, and also people who were not employed. And so people had the opportunity to learn from one another, to have role models within the community, and to have mentorship, even if that mentorship did not exist within their biological family, because there was much more of a village and community feel around the support and well-being. Come 1960s and 70s, with the loss of the middle class, leaving the communities and going into communities that were much more segregated in terms of class, a loss of that capital, social capital network and infrastructure took place. Concentrated pockets of poverty, not having the kinds of supports that are needed for African American young men and young women, and then subsequent problems. You should take a look at some of the work that took place in the 1960s from then Professor Daniel Patrick Moynihan, who was later a senator here in the United States, around the state of what was called the Negro family during the 1960s, in order to get a sense of some of the genesis around it.
Sure, and what I'll just say is I did have an opportunity to travel to Omaha, Nebraska a few years back, so I bear witness. We're out there. Yeah. Yeah, so I'll just say, as far as the CeaseFire program, we actually have women in every single program role that this program offers, from violence interrupters, outreach workers, management, upper management, and in Chicago and really across the nation. I mean, probably one of the largest population of the prison population is women. And a lot of people aren't aware of that, but I mean, in Chicago and in various cities and in countries, women do play a very unique, specific role as far as violence is concerned. And oftentimes, violence is instigated, by women. In a lot of cases, a lot of men, they shoot and kill in our communities about females. And so the thing is, when we have our female violence interrupters, and I'm thinking of them right now, a lot of times, even when they're conducting conflict mediations, it's a different element. It's a different feel in that, oftentimes men are a lot, especially, people don't like you getting in their business, period. And so when you're mediating a conflict, if you end up in a situation where you don't have relations on both sides, people are going to be, they're going to be grilling you. They're going to be, they're not going to want you to be getting in their business. But sometimes when you have a female violence interrupter that's approaching this male, it's less of a threat. And so they may be more open to actually listening, and we may be able to actually navigate that situation a lot better. So I think that both women and males, they're complementary in these roles as far as reducing violence. And we have the same way we've had male focus groups and male summits. We've had just some female only type of focus groups where our female outreach workers and violence interrupters work with this population and talk about the issue specific to the women population.
One thing I wanted to speak to really quickly is on this issue of gender violence. Obviously, women are much more at risk for intimate partner violence, but some of that is being addressed as part of the Violence Against Women programs, part of how we socialize men. And I guess what you call patriarchy, sexism, whatever, there is this overlay of strength, there is this overlay of control that can also translate into violence. So some of the preventive efforts are to help educate both women and men about how to enter into healthy relationships. So that's part of some of the prevention programs that are out there. They're very much underfunded, but there are different programs that deal with them at different levels. But again, it's a really important discussion to have in terms of why women may be at risk for certain types of violence. But I think increasingly, what you mentioned, more and more young girls are engaging in violence within their schools. More and more young girls are being arrested, and they're also entering the school to prison pipeline. That's of concern to all of us.
From what I've been told, we only have time for one more question. I would say after this, our panelists will be around afterwards. So if you have a question, you can ask the panel or myself any questions afterwards. The lady here. No, I was referring to you.
Good afternoon. I'm a former federal employee, but I'm not any longer, so I'm free. But I have had experience inside and outside the government working on violence prevention in the community, particularly in Chicago. And I know that we fund, I want to just focus on dissemination and adoption, just to make it quick. We fund so much research around violence and other issues, but we're talking about violence today. And actually, out of that research, there come studies that have been shown to be effective and have actually received funding to disseminate that. But often, we kind of do that short term, and then the programs are gone, and we have not actually done an adequate job of disseminating what we spent billions of dollars on having someone research. So it's not that we so much just need to continue to fund research, which we're just recycling, because the studies have already been done, and so now 10 years later they can say, let's maybe do a study again and see what we come out of it. But let's put more money into dissemination and adoption and use, and let's utilize various parts of the federal government who can do that. I know I used to work in the Office of Minority Health, so I know that we have programs there that we can do that. But the money is so small that many communities can't really do an adequate job. And so that's where I think we need to put more attention and more resources into being able to take what Pure Balance is doing in Chicago and spread it more widely, to take programs that have been effective in bringing parents and schools and kids together to work on violence in their own communities, such as one of the proven evidence-based funded by NIH called the Obama Youth Project. There are many others, and if we could do that, I think that we would begin to maybe chip away at that iceberg in a more of a comprehensive way, rather than just focusing on a couple of areas.
All right, well, that concludes our panel discussion. Thank you all for coming out, and please give our panelists a round of applause.